This module is titled Hepatitis and Cirrhosis. The learning objectives for this module include: describe the clinical manifestations, nursing management, and complications of patients with various types of hepatitis, and to differentiate the clinical manifestations, complications, and nursing management of the patient with cirrhosis of the liver. More than 500 vital functions have been identified with the liver. A few main functions are listed here for you. The liver assists in metabolism of carbohydrates, proteins, and fat. It also detoxifies substances that are ingested. It is needed for steroid metabolism. The liver produces bile. The liver also has many storage capabilities. It stores glucose, fat-soluble and water-soluble vitamins, fatty acids, minerals, and amino acids. The next couple slides will just provide images for you to refresh your memory about where the liver is located and the anatomy of the liver.
Hepatitis is a broad term that means inflammation of the liver. Hepatitis is most commonly caused by viruses, but can also be caused by drugs, chemicals, autoimmune diseases, and metabolic disorders. The types of viral hepatitis are A, B, C, D, and E. They differ in their modes of transmission and their clinical manifestations. Other less common viruses can also cause liver disease. These include cytomegalovirus, Epstein-Barr virus, herpes virus, and the rubella virus. Hepatitis A is a viral infection that can cause mild flu-like illness or acute hepatitis with jaundice. It can also cause acute liver failure, but it does not result in chronic infection. Hepatitis A is transmitted primarily through fecal-oral route. It frequently occurs in small outbreaks where there is fecal contamination of food or drinking water. Poor hand hygiene, improper handling of food, poor sanitation conditions are contributing factors. Transmission can also occur between family members, institutionalized individuals, and children in daycares. Hepatitis B virus can cause either acute or chronic disease. Transmission occurs when the virus from an infected body or body fluid enters the body of an uninfected person who has not received the hepatitis B vaccine. It can be transmitted perinatally by mothers infected with HBV. It also can be transmitted percutaneously through IV drug use, accidental needle sticks, or by mucosal exposure to infectious blood products, or other body fluids. Sexual transmission is a common mode of HBV transmission. Men who have sex with men are at high risk for HBV infection. Hepatitis C can result in both acute and chronic illness. Acute hepatitis, which is usually asymptomatic, can be difficult to detect unless diagnosed with laboratory testing. The most common cause of hepatitis C are injection drug use and outbreaks among HIV-positive men who have sex with men. The majority of patients who acquire hepatitis C usually will develop chronic infection. Hepatitis D virus cannot survive on its own. It requires hepatitis B to replicate. It can be acquired at the same time as hepatitis B, or a person with hepatitis B can be infected with hepatitis D at a later time. Hepatitis D is transmitted percutaneously, similar to hepatitis B, and it causes a spectrum of illnesses ranging from asymptomatic chronic carrier to an acute liver failure. Currently, there is no vaccine for hepatitis D. Hepatitis E is transmitted by fecal-oral route. It's usually transmitted by drinking contaminated water, and it's primarily found in developing countries. Very few cases have been reported in the United States. Clinical manifestations of viral hepatitis can be classified into acute and chronic phases. The acute phase usually lasts 1 to 4 months. During the incubation period, symptoms may include malaise, anorexia, weight loss, fatigue, nausea, vomiting, and abdominal pain, typically in the right upper quadrant. Physical examination may reveal hepatomegaly, lymphadenopathy, and splenomegaly. The acute phase may be icteric or anicteric. In the icteric phase, the patient is jaundice. Jaundice is a yellow discoloration of body tissues resulting from an alteration in normal bilirubin metabolism or flow of bile into the hepatic biliary duct system. There's different types of jaundice. There's hemolytic, hepatocellular, and obstructive jaundice. In anicteric hepatitis, there is no jaundice. But after 3 months, jaundice may disappear, but this does not mean that the patient is improving. The chronic phase, also called the convalescent phase or the post-icteric phase, begins as jaundice fades. It lasts for several weeks to months, with an average being 2 to 4 months. During this period, the patient's major complaint is malaise and fatigue. Hepatomegaly remains for several weeks, but splenomegaly typically subsides during this period. The only way to distinguish between the various types of hepatitis is to test the patient's blood for specific antigens or antibodies. The different tests for viral hepatitis are presented here. A liver biopsy is not indicated in acute hepatitis unless the diagnosis is in doubt. In chronic hepatitis, a liver biopsy may be done. Biopsy of liver tissue allows for histological examination of liver cells and characterization of the degree of inflammation, fibrosis, or cirrhosis that may be present. Pre-procedurally, the nurse must verify or identify patients who are at risk for bleeding, so evaluation of coagulation studies is necessary. A patient may need a blood transfusion or blood products prior to the procedure. During the procedure, the patient will be positioned in a supine left lateral position. They will be asked to hold their breath after expiration while the needle is inserted. Post-procedurally, the patient will be asked to lay on their right side to splint the area with a pillow underneath their costal margin. They will be on bed rest for approximately 12 hours. And post-procedurally, the nurse will monitor for hemorrhage and peritonitis. There's no specific treatment or therapy for acute viral hepatitis. Typically, the patient can be managed at home. The person should get adequate nutrition, hydration, and rest. Currently, there are no specific drug therapies, but supportive therapy can focus on treating symptoms, such as the use of antiemetics or nausea. The treatment for chronic hepatitis B is focused on decreasing the viral load, decreasing liver enzyme levels, decreasing the rate of disease progression, and decreasing the rate of drug-resistant hepatitis B virus. The long-term goals are to prevent cirrhosis of the liver and liver cancer, but unfortunately, not all patients respond to current treatment regimens. Current drug therapies for chronic hepatitis B do not eradicate the virus, but they work well to suppress viral replication and prevent the complications of hepatitis B. Interferon has multiple effects on viral replication cycle. Long-acting preparations, pegylated interferons, are administered subcutaneously once a week for about 48 weeks. These medications have long-acting preparations, so their blood levels remain high between doses, and therefore their clinical responses are better. These long-acting preparations are made by conjugating a standard interferon with polyethylene glycol, or PEG, in a process known as pegylation. Nucleoside and nucleotide analogs fool the virus into thinking there are normal binding blocks for DNA, making the virus unable to reproduce. The side effects of nucleoside and nucleotide analogs are infrequent, and they may be used instead of interferon because they are tolerated better. Treatment for chronic hepatitis C is focused on eradicating the virus, reducing the viral load, and decreasing the progression of the disease. Treatment consists of using PEG interferon alpha 2A with ribavirin. Ribavirin does have a number of side effects, which include anemia, anorexia, cough, rash, pruritus, dyspnea, insomnia, and tetrotoxicity. It is important to teach our patients about prevention. Hepatitis A can be prevented through good hand washing and good hygiene, as well as immunization. Hepatitis B and C can be avoided through good hand washing, avoiding sharing personal products, hepatitis V vaccine, and use of infection control precautions can help avoid acquiring hepatitis C. Most patients with acute viral hepatitis will recover completely. Hepatitis C infection is more likely than hepatitis B to become chronic. Patients with chronic hepatitis C infection run the risk of developing chronic liver disease, cirrhosis, and a hepatocellular cancer.
Nursing interventions include teaching the patient how to prevent spread of the disease. Dietary teaching is also necessary. There's no emphasis on a special diet, but the patient should know that they should eat a well-balanced meal that they're able to tolerate. Usually 6 small meals a day will be helpful. If they're having a hard time tolerating the fat content in their diet because of decreased bile production, they should try to reduce the fat content in their diet. Vitamin supplements such as B-complex vitamins and vitamin K are frequently used. And also if patients experience anorexia, nausea, and vomiting, it's suggested that they take antiemetics prior to mealtime. Patients should also know to assess for complications. They should be aware of potential bleeding complications, signs and symptoms of encephalopathy, and signs and symptoms of recurrence. They should make sure that they have regular follow-up appointments scheduled with their physicians at least once a year. They will also need medication education on how to give themselves the subcutaneous interferon injections, and they also need to know the side effects regarding this medication. Cirrhosis is a chronic progressive disease of the liver characterized by extensive degeneration and destruction of liver cells. It is the 8th leading cause of death in the United States and is twice as common in men than in women. The development of cirrhosis is an insidious, prolonged course, usually after decades of chronic liver disease. Any chronic liver disease, including diseases from excessive alcohol intake and non-alcoholic fatty liver disease, can cause cirrhosis. The specific cause of cirrhosis is not determined in all patients, but the most common cause in the United States is alcohol-induced liver disease and liver disease caused by chronic hepatitis. Biliary causes, such as chronic obstructive biliary disease, can cause cirrhosis, as well as cardiac cirrhosis can be caused by hepatic damage that results from long-standing severe right-sided heart failure. A variety of tests can be done to evaluate liver function. Liver function studies will usually return with an elevated alkaline phosphatase, AST, ALT, and GGT. Electrolytes may be involved, oftentimes from poor nutritional intake. CBC may also be evaluated. You'll be evaluating the patient's hemoglobin and hematocrit. Prothrombin time may be prolonged. Serum albumin and protein levels will be decreased, and bilirubin and globulin levels will be increased. Liver ultrasounds, CAT scans, endoscopy, and liver biopsies are all done to determine the severity of the cirrhosis. The onset of cirrhosis is usually insidious. Early symptoms can include anorexia, dyspepsia, flatulence, nausea, vomiting, change in bowel habits such as diarrhea or constipation, and in some they may have fever and abdominal pain. Later manifestations may be severe and result from liver failure and portal hypertension. Jaundice occurs as a result of the decreased ability of the liver to conjugate and excrete bilirubin. Spider lesions, such as spider angiomas, can occur on the nose, cheeks, upper trunk, and neck. And this results from an increase in circulating estrogen because the liver can no longer metabolize steroid hormones. Hematological disorders, such as anemia, leukopenia, thrombocytopenia, are probably caused by splenomegaly. Coagulation problems result from the liver's inability to produce prothrombin and other factors essential for clotting. Endocrine problems result because of adrenocorticoid hormones, estrogen, and testosterone that cannot be metabolized and activated by the liver. Peripheral neuropathy is probably caused by the dietary deficiencies of thiamine, folic acid, and cobalamin. You can see here when the liver fails that there can be systemic manifestations. You may see neurological, GI, reproductive, skin, hematological, metabolic, and cardiovascular side effects or symptoms throughout. The major complications of cirrhosis are portal hypertension, with resultant esophageal and gastric varices, peripheral edema and ascites, hepatic encephalopathy or coma, and hepatorenal syndrome. Portal hypertension is characterized by increased venous pressure in the portal circulation, splenomegaly, large collateral veins, ascites, and gastric and esophageal varices. Varicosities may develop in areas where collateral and systemic circulations communicate. This results in esophageal and gastric varices. Caput medusae are a ring of varices around the umbilicus. You also may see increased hemorrhoids in these patients. Esophageal varices are a complex of tortuous veins at the end of the esophagus, which are enlarged and swollen as a result of portal hypertension. Gastric varices are located in the upper portion of the stomach. These collateral vessels contain little elastic tissue and are very fragile. They tolerate high pressure poorly and as a result can bleed very easily. Bleeding esophageal varices are the most life-threatening complication of cirrhosis. Patients may have blood in their stool or blood in their urine, and this may be because of slow bleeding, but a massive bleed can also occur, which would then be considered a medical emergency. Ascites is the accumulation of serous fluid in the peritoneal or abdominal cavity. When a person has portal hypertension, proteins move from the blood vessels by the way of larger pores or capillaries in the lymph space. When the lymphatic system is unable to carry off the excess proteins and water, proteins begin to leak into the peritoneal cavity. Peripheral edema results from decreased colloidal osmotic pressure due to impaired liver synthesis of albumin and increased pressure from the portal hypertension. Peripheral edema typically occurs in the feet, ankles, and presacral areas. Hepatic encephalopathy is a neuropsychiatric manifestation of liver disease. When the blood is shunted past the liver by the way of the collateral vessels of the liver, or the liver is unable to convert ammonia to urea, the levels of ammonia in the systemic circulation begin to rise. Ammonia crosses the blood-brain barrier and produces neurological toxic manifestations. Someone with hepatic encephalopathy typically has changes in their neurological status and mental responsiveness. This can range from lethargy to deep coma. A classic symptom of hepatic encephalopathy is flapping tremors. It's a rapid flexion and extension movement of the hands when the arms and the hands are held stretched out. Hepatorenal syndrome is a type of renal failure with advancing azotemia, oliguria, and intractable ascites. In hepatorenal syndrome, there is no structural abnormalities of the kidney. In a patient with cirrhosis, this syndrome frequently follows diuretic therapy, GI hemorrhage, or if the patient has a paracentesis. Nursing interventions will include making sure the patient is able to rest while they still get some activity. The diet for a patient with cirrhosis without complications is a high-calorie diet typically about 3,000 calories a day, with high carbohydrate content with moderate to low levels of fat. Patients should be instructed to avoid alcohol. Patients with ascites and edema should be on a low sodium diet. Patients with hepatic encephalopathy will need to have their protein intake restricted. And patients will need to have vitamins and supplements that are easily metabolized by the liver. And as the nurse, you will not want to make sure that you instruct your patients on the signs and symptoms of complications and that you know how to manage these complications. The management of ascites focuses on sodium restrictions, diuretics, and fluid removal. The amount of sodium restriction depends on the patient. Typically it's about 2,000 grams per day, but in severe cases it may be as little as 250 to 500 milligrams per day. Diuretic therapy is also an important part in the management of ascites, and oftentimes they may be on a combination of diuretics. With diuretics, though, one must always monitor electrolyte levels. A paracentesis is a needle puncture of the abdominal cavity, and it is performed to remove the ascites fluid or to test the fluid for infection. This procedure typically is done for those with severe ascites that results in respiratory distress or pain. Paracentesis is only a temporary fix because the fluid will reoccur. A peritoneal venous shunt is a surgical procedure that provides continuous reinfusion of ascites fluid back into the venous system. But this procedure is used rarely because of its high rate of complications. When a paracentesis is planned, you want to have the patient void immediately before the procedure to prevent puncture of the bladder. Typically the patient will be in a high Fowler's position or will be sitting on the side of the bed. After the procedure, you should monitor for hypovolemia and electrolyte imbalances, and you want to make sure you check the dressing for bleeding and leakage. Here is an image of the peritoneal venous shunt that was previously described. The main therapeutic goal for esophageal and gastric varices is to prevent bleeding and hemorrhage. A patient who has esophageal varices should avoid alcohol, aspirin, NSAIDs, or any irritating foods. If a patient develops a respiratory infection, they want it to be treated promptly. There are some medications that can be given during an acute bleed. This would be octreotide and vasopressin. And the main goal is to stop the bleeding until treatment measures can be instituted. IV administration of vasopressin produces vasoconstriction, which decreases portal blood flow and decreases portal hypertension. Because the side effects of vasopressin can be decreased coronary blood flow, dysrhythmias, and increased blood pressure, nitroglycerin is often given in conjunction with the vasopressin. If you suspect an acute bleed due to esophageal varices, or the patient is actively bleeding from esophageal varices, airway is going to be extremely important. Because the person can have an extreme hemorrhage from these esophageal varices, it would be very difficult to insert an endotracheal tube once the patient is actively bleeding. So we want to always make sure that our patient has a stable airway. Next, it would be very important for you to insert an IV, a large IV. Typically an 18 gauge or 20 gauge would be preferred. If your patient seems to be crashing quickly or you suspect that, then you'd want to probably have 2 IVs in your patient. You would suspect if the patient is bleeding that you will probably be giving blood products, so you might get set up for that or anticipate those orders or verify that maybe those orders are already written. The patient may also receive platelets Medications you might expect to administer might be vitamin K. So if the patient has a high PT or INR, vitamin K is the antidote, so that would decrease the high PT and INR, so the patient is not at such a high risk for bleeding. Lucetride and vasopressin was discussed on a previous slide. You would anticipate giving those medications. And you may anticipate that the physician will want an endoscope. They may want to do the procedure. Now, if this is a med-surg patient on a med-surg unit, this patient would probably be getting transferred to the ICU as soon as possible. But in the meantime, these are the things that the med-surg nurse would be thinking about. An endoscopic procedure is typically not done at the bedside on a med-surg unit, but it may be done at the bedside in the emergency room, in the ICU, or they would transport them to the GI lab or wherever they do these type of procedures within your hospital. During an endoscopic procedure, sclerotherapy or band ligation may be used to prevent bleeding. Sclerotherapy involves the injection of a sclerosant solution into the varices through an injection needle that is placed through the endoscope. Endoscopic variceal ligation, or banding, is performed by placing a small rubber band around the base of the enlarged vein. Balloon tamponade may be used in patients with acute esophageal or gastric variceal hemorrhage that cannot be controlled by endoscopic procedures. Balloon tamponade controls the hemorrhage by mechanical compression of the varices. Different types of tubes are available. The Sengstaken-Blakemore Tube, which is here for you in an image, has two balloons, gastric and esophageal, with 3 lumens. One is for the gastric balloon, one for the esophageal balloon, and one for gastric aspiration. There is a high incidence of recurrent bleeds for patients with esophageal varices, and their mortality risk increases with each recurrent bleed. Long-term management of patients who have had an episode of bleeding includes being on a non-selective beta blocker, such as propranolol. They may need repeated band ligation of the varices. They also may need shunts. The transjugular intrahepatic portosystemic shunt is a non-surgical procedure typically performed by a radiologist. The shunt is placed between the systemic and the portal venous system. By doing this, it decreases the venous pressure and therefore will decrease the varices. So during the TIPS procedure, a catheter is placed in the jugular vein and threaded through the superior and inferior vena cava to the hepatic vein. The wall of the hepatic vein is punctured and a catheter is directed to the portal vein. Stents are then put in position, overlapping into the liver tissue and extending into both veins. This procedure will then reduce the portal venous pressure, and it will cause the varices to decompress. This will help decrease the risk for bleeding, or decrease bleeding if it's occurring. If someone has a TIPS procedure, they are still able to have a liver transplant in the future. But the TIPS procedure is not advised for patients with severe hepatorenal syndrome or if they have a portal vein thrombosis. The surgical shunts most commonly used are the portocaval shunt and the distal splenorenal shunt. The portocaval shunt is the one labeled A. In this procedure, the portal vein is anastomosed to the inferior vena cava, diverting blood from the portal vein to the systemic circulation. In the distal splenorenal shunt, the splenic vein is anastomosed to the renal vein. The portal venous flow remains intact while the esophageal varices are selectively decompressed. The spleen conducts blood from the high pressure of the esophageal and gastric varices to the low pressure renal vein. The goal of management of hepatic encephalopathy is the reduction of ammonia formation. Ammonia formation in the intestines is reduced with lactulose, a drug that traps ammonia in the gut. This medication can be given orally, as an enema, or through an NG tube. The laxative effect of the drug expels the ammonia from the colon. The problem with this medication, though, is that many patients do not take it because of the severe diarrhea that it can cause. Rifaximin and neomycin are alternative medications that can be given instead of or in conjunction with, and these decrease the bacterial flora and decrease the formation of ammonia. Nursing care for the patient with cirrhosis typically focuses on conserving the patient's strength while maintaining muscle tone. So it'll be important to modify activity and rest. If the patient happens to be on bed rest, it'll be important for you as the nurse to implement measures to prevent pneumonia, blood clots, and pressure ulcers. Nutrition is also very important. Oftentimes patients may feel anorexic and have nausea and vomiting due to the ascites, so we want to make sure they're getting adequate nutrition. They may also need to get IV fluids if the patient is not taking in enough fluids. Watching for electrolytes and replacing electrolytes will also be important, because many times these patients are taking diuretics, so you can see changes in their sodium, potassium, chloride, and bicarbonate levels. You'll be accurately monitoring how much they put in and how much they take out. These patients will need to be weighed daily. You also might be measuring for abdominal girth. That may be done once a day or once a shift, depending on the severity of cirrhosis of your patient. And you'd be measuring to see if the abdominal girth is increasing, which means that there is an increase in ascites. And you may also be preparing your patient for paracentesis to remove some of that ascites fluid. With a patient with liver cirrhosis, you will do a head-to-toe assessment. You will be assessing for hematological variations and possible bleeding concerns, and expecting to intervene with either blood product administration or the administration of vitamin K. Respiratory assessment is important. We always want to make sure we have a stable airway, and we also want to make sure we try to identify any respiratory infections or signs and symptoms of aspiration right away. Cardiovascular, you're assessing for edema in the lower extremities. You're also watching for electrolyte imbalances, which can sometimes be manifested by dysrhythmias, hypotension, tachycardia, generalized muscle weakness. Renal function will also need to be monitored, monitoring I&O, as well as monitoring BUN and creatinine levels. Neurologically, you want to make sure you're watching for any signs and symptoms of hepatic encephalopathy, any changes in mental status, increased confusion. Skin care is very important for several reasons. If the patient is on bed rest, we want to monitor their skin. If they are edematous, they have increased risk for skin breakdown. We'll be monitoring their skin for jaundice and their eyes to see if their sclera have changed to that yellowish hue. Range of motion exercises will also be important to promote circulation if the patient is on bed rest. Self-image is always a concern for these types of patients, because now they may have a change in their skin color, they have a very large abdominal area, swelling in their extremities, which can be difficult for some people to handle. And safety is also an additional concern for many reasons. A few to mention is that they are at risk for encephalopathy, so they have increased risk for confusion, If the patient has a lot of swelling in their lower extremities, they may have difficulty ambulating, which puts them at risk for falls. So there are many safety concerns for your patient with liver cirrhosis. Prevention and early treatment of cirrhosis focuses on reducing or eliminating risk factors. So alcoholism must be treated, or patients should be advised not to drink alcohol. Adequate nutrition, especially for those who are using alcohol, is extremely important. You also want to identify and treat acute hepatitis early so that it does not progress to chronic hepatitis or cirrhosis. And if the patient does have liver cirrhosis and is being discharged from the hospital, it's important that we make sure that we educate them on the signs and symptoms of complications, when they should be seeking treatment. They also need education on diet, rest. They need to be told which drugs are hepatotoxic, such as Tylenol, and they should be told to avoid those drugs. And they also need to be taught about avoiding alcohol or seeking treatment for alcoholism.